Okay, I'm just getting water. I'm sitting.
Hello for all you stalwarts still here. I'm Dr. Gonzales, a psychiatrist in Ogden, and I've been involved, as most of you know, since 1988 with the Ogden Surgical Medical Society. And really, it's one of my most anticipated annual events, and really my most beloved. Typical examples of why I love this meeting. We had a Wednesday lecture from Dr. James O'Neill, and he just opened up our hearts about sharing our knowledge with third world countries or other underprivileged places and tethering our skills to action. And then after that, there was a lecture on hepatitis, which now gives me a chance to try out one of my favorite words, an abecedarian. I think you can't study liver chemical and clinical effects without learning the student of the alphabet, because it was one big alphabet soup. And today, I'm very, very thrilled to have two people that I knew, one vaguely personally, Dr. Abraham Morgentaler and Dr. Alan Altman, who are going to speak about hormone replacement in women, what the latest in the research is, and how we can translate that into being better physicians for many of our patients. And I think a lot of you are here because any of us over 40 will probably find this personally very interesting and perhaps life-changing. So now I'm going to introduce Dr. Abraham Morgentaler, who was born in Montreal, Canada. I was amazed. They never have an accent like me from Brooklyn. He graduated from Harvard College in 1978 and from Harvard Medical School in 1982. Dr. Morgentaler completed his residency in '88 from the Harvard program in urology and then joined the faculty of Beth Israel Deaconess Medical Center and Harvard Medical School. He is currently an associate professor of surgery and urology, and in 1999, Dr. Morgentaler founded the Men's Health Boston, a center focusing on sexual and reproductive health for men. Dr. Morgentaler was the recipient of the New Investigator Award in 1994, granted by the American Foundation of Urologic Disease. Dr. M is an international authority on men's health, and in particular testosterone deficiency in men. He was one of the first to recognize and treat the decline in testosterone seen with aging, often called male menopause or andropause. And Dr. Morgentaler's research has been instrumental in teaching a new generation of physicians, and some of us old ones too, that testosterone therapy is not risky for prostate cancer, reversing a belief that was held for 70 years. Dr. M has also published widely on male sexual dysfunction and male reproductive disorders. Dr. Morgentaler has published over 120 scientific articles, and his work has appeared in the New England Journal of Medicine, The Lancet, the Journal of the AMA, Cancer, and the American Journal of Medicine. He's also the author of popular books, and you can make them more popular by buying them: Testosterone for Life, Recharge Your Vitality, Sex Drive and Muscle Mass and Overall Health, and The Viagra Myth. Oh, can I tell a Viagra joke? You know what happens to a lawyer if you give him Viagra? He gets taller. Okay. The surprising impact on love and relationships. And now his latest book, which I understand is, you can purchase it out front. Dr. Morgentaler has to leave early, so he's pre-signed some books if any of you still want to. Well, I think you will after hearing the talk, because it's called Why Men Fake It, The Truth About Men and Sex, so maybe women want to buy it too, and it was published last April.
Well, thank you for that lovely introduction. It's great to be here. And I want to talk to you about a topic that's near and dear to my heart that I've been working on for most of my life, really, which is this testosterone business. You hear about it everywhere. And I've called this talk Testosterone Therapy in Men, Panacea, Scourge, or the Next Big Thing in Medicine. So I would assume that you guys get the same kind of ads that we get in Boston about low T centers, and is it low T? It's on television. You read about testosterone and athletes cheating. The guy Pistorius, the Olympic guy with the prosthetic legs, who allegedly killed his girlfriend. Like there were these headlines that they found testosterone in his room, which it wasn't. And we hear about testosterone everywhere. And what's amazing about it is that it's been around since 1930s, and we know less about it in some ways and more misconceptions than we do about drugs that really have been introduced to the markets just over the last few years. I think as a physician, it's hard to make sense of it all because there's so much information mixed in with misinformation. There was a study that was reported, I read in the New York Times the other day about a monkey study. I like the monkey video next door. It was a monkey study. And there was one male who behaved differently from the others, and the investigator was asked, why was this guy different? And she said, I don't know, maybe he had high testosterone. We attribute everything in male behavior, whether good, bad, or ugly, to testosterone, and I want to talk to you a little bit about that. But one thing is for sure is that this is actually the fastest growing class of medicine over the last 10 years. Something is happening, whether you're prescribing it or not, your patients are hearing about it and want to know about it and are considering it. And I think there are a couple of reasons it's taken off now after however many decades. One of the issues that's less of an issue now is the prostate cancer one. I think we have better treatment modalities than when I started, and we have public awareness. And then I think there's a lot of integrative or age management medicine that's really been keyed in on hormones for some time that's starting to sort of pick up the gauntlet about this. Let me tell you how I got started. I was an undergraduate at Harvard. I was a little bit lost. I had taken biology. I ran into this one guy in Harvard Square who had been my teacher. He says, what are you doing? I said, not much. Just come to my lab. I think you'll like it. And in his lab, it was a reptile lab. He had lizards and he had snakes. And I worked with these guys. This is Anolis carolinensis, the American chameleon. If you go to Florida or the Bahamas, you see these guys. They're about yay long. They run up the walls and the trees. And that's a male there up here. That's a female. And when the male sees the female, this bright colored flap of skin comes out called a dewlap. And then his head bobs up and down very quickly. We call it a stuttering push-up. And it's almost like the male is going, yeah, 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 yeah. The female, if her ovaries are intact, will do a very delicate, stately push-up back, which basically says, I'm okay, I'm here. The male comes closer, they repeat the behaviors, dewlap comes out, yeah, 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 and then they mate. Cool. So I wasn't ready to go into medicine or knew that I was going to be a urologist, but my first operation ever was actually a bilateral orchiectomy. I removed the testicles on these males. And if you castrate the males and you put them in with the female, they don't do anything. They don't care. The female will do a little push-up sometimes and say, hey, buddy, I'm over here, and the male doesn't care. And my experiment, which at age 19, and I was in the lab for 3 years, 20 and 21, was beyond cool, was to take tiny amounts of crystalline testosterone, drill a hole in the skull of these guys, the males, and to insert tiny amounts of testosterone into what we knew were the sexual centers of the brain, which was the anterior hypothalamus and preoptic area. And if we did that and I got in the right place, we would take these castrate males, put them in the cage with the female, no circulating testosterone. They'd see the female, the dewlap would come out, and the head would go, yeah, 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 yeah. Putting hormones in the brain was enough to restore the entire range of sexual behavior of these animals. It's amazing. So that was pretty neat. Then I went to medical school, and I learned what all of you learned. Testosterone is important for male differentiation and as the fetus. It's involved in puberty, and it has these effects in the adult male. But 6 years of urology residency, we didn't give testosterone to a single guy. As a matter of fact, by the time that I finished my training in the 1980s, the only people that were getting testosterone were really these groups. So men who had genetic issues like Klinefelter's, where they have bad testicles, men who'd had pituitary tumors or hypothalamic issues radiated or resected, so they didn't make any gonadotropins to stimulate the testicles to make T, or men who had lost their testicles from trauma or cryptorchidism or cancer. That was it. So I come out, I start my own practice in the hospital. I'm doing sexual medicine, reproductive medicine, and I'm inspired by my lizards. So I'd heard all my life from women that men are just like lizards, so I said, let's find out if it's true. And I started checking testosterone levels in these guys who had come in, and I was surprised at how many of these guys had low levels of testosterone. And then I said, what happens if we treat him? But I didn't know how to treat him. So we were in a multidisciplinary area, and there's a woman endocrinologist who I knew and trusted. I said, how do you treat with testosterone? And she said, oh, it's easy. You give an injection once a month, every 4 weeks. So I had a nurse. I lined up a few of these patients, and I had my nurse give them an injection every 4 weeks. And at the end of 3 months, I had a few of them lined up. I said, what'd you notice? And what made me a believer in this is two things. One is the guys would come in and they'd say, it was good. Doc, it's great. I mean, my sex drive is better, my erections are better, but I'm better in ways you never even told me. Like my mood is better, my wife says I'm nicer to be around. Okay, but maybe it's a placebo, right? I mean, these guys know they're getting like the male hormone, right? But the thing that really convinced me was when a few of them said to me, Doctor, the interesting thing, though, is that for the first couple of weeks after you give me that injection, I feel great. But for a week or two before my next injection, I feel like you never treated me. What's up with that? And the answer was I didn't know what was up with that, so we started to check levels, and it turns out by 14 days, almost every man who gets an injection is back down to his baseline T. It's a version of a double-blind experiment. The men didn't know what to expect, and frankly, nor did I. But what I learned from it was that the men could tell when their levels were good, and they could tell when their levels were down. It was real. And so I started doing more and more of this, but especially as a urologist in the late 80s, we were worried about prostate cancer. So PSA had come in, we were doing biopsies like crazy. We were crazed about prostate cancer. To some extent, we still are. And I was afraid that by giving testosterone to these men, and I didn't have a single colleague that I knew of or trained with that was doing this stuff, I was afraid that I was going to precipitate, we were learning that there were occult prostate cancers everywhere. And I was afraid it was going to be like a bargain with the devil. They're going to feel better, but they're going to have prostate cancer. So I started doing something that I'm going to tell you about in a minute about trying to figure out the prostate cancer story. But where are we today? These are what the symptoms are of low testosterone. Now everybody's out there with it, but then it was new. I like to break it up into sexual and non-sexual symptoms. Sexual symptoms are libido is decreased, erectile dysfunction, some men have difficulty achieving an orgasm, men get fewer nocturnal or awakening erections. The non-sexual symptoms tend to be diminished sense of energy. Guys feel like they've lost their vitality. They don't feel as good. They're tired. Some guys take naps after meals that they never did. I had one guy, you probably have this too, we have them fill out a form, says, what are you here to see the doctor for? And they list their meds and stuff. And one guy wrote, the sofa speaks to me. So I didn't know if he's psychotic or what, but I walk in the room, and he seems like a nice guy, and he's funny. And I say, what's it all about? And he says, Doc, I'm a guy that's always busy. I have 2 jobs, not because I need the money, but because I want to be busy. I have a shop, nighttime, weekends, I'm always doing something. The last year or so, every time I cross the living room floor, I hear the sofa say, come, lie down, take a nap. He says, it's not me. He'd been to his primary care doctor. They checked him for thyroid. It was fine. Nobody had anything for him. And somebody suggested he see me. And sure enough, he had low testosterone. So we treated him, came back and follow up. How you doing? He says, the sofa doesn't speak to me anymore. So it's a hard thing sometimes to define, but guys often know if they're not right. And often their partners know if they're not right too. It's just missing that little bit. Most of what makes many of you and me successful, I like to call the extra 5%. It's like you can get through your day with 5% less, you'll be all right. But it's the 5% that gives you your happiness, your energy, your sense of achievement. It's like this extra little bit. And that's what guys often will lose. Some guys with low testosterone will notice that their mood is blunted. They don't feel as happy. They don't laugh as loud at jokes. They may know it's funny, but they don't sort of engage in the same way. And the flip side of that with mood is men can have irritability, short fuse, sort of grumpy old man syndrome before their time. Some guys they feel like they've got a brain fog. They just don't feel sharp. And then there are objective things that you can measure, like decreased bone mineral density. We get DEXA scans, and all the guys come in with low testosterone. because it's associated with decreased bone density and osteoporosis. Guys will notice at the gym that every guy here who's done any workout ever, there's probably not one of you that has worked out consistently every day or every week for the last 10 years. We all take breaks for one reason or another. There may be a couple of exceptions, but we take breaks. Something happens, right? And then you know that when you restart, there's a certain way that you can build up, right? Like you can do more push-ups, more sit-ups, whatever. And like that's just a feeling that guys have. And some of the guys will go to the gym and they just can't progress at all. Guys put on fat, especially around the middle. You can see some gynecomastia, which is from fat usually. And we see men who have anemia. If you go to lectures on how to diagnose who's really got this, sometimes it feels like you need a PhD in Fourier transformation because it gets really complicated. We have so many tests now that people talk about, and nobody agrees on what level is low. So we have total testosterone, free testosterone, bioavailable testosterone, free androgen index. A well-known guy from the University of Pennsylvania says nobody should be treated unless their testosterone is less than 200. FDA uses the number 300. The Europeans use 348. Complicated. I'm going to make it easy. See this male? King of the jungle, king of the plains. This is a male with normal testosterone. See this poor guy? This is a male with low testosterone. Now here's the thing. All of you have patients that look like this poor guy who used to look like the other. As a matter of fact, maybe some of you in the audience, I'm not going to point anybody out, some of you look like maybe used to look like the other guy too. It's a syndrome. It's not like one specific thing. If you do treat, we see a number of things that are good that happen. I think the hallmark is around sexual stuff. Sexual desire goes up. This is a 3-year gel study. Erections improve. Positive moods improve, stay improved for 3 years. Negative moods go down. It's a lot of good stuff that happens, and some of the guys will come back and they say something really neat, which is they say, I feel normal again. I feel like myself again. That's rare in medicine to have that experience. So in terms of the diagnosis, it's a clinical syndrome. It's not just the blood tests. It's you have to have characteristic symptoms or signs that go along with reduced levels of testosterone. A lot of speakers really make the blood test the primary thing. I believe the complete opposite. I think it's the symptoms that are paramount, and the blood tests are used as a confirmation. If you're going to get blood tests, this is a helpful little figure to understand what it is you're getting. So if the whole pie is total testosterone, which is what all of you trained on, half or a little bit more or less, depending on the study, is bound to sex hormone binding globulin. What's important about that binding is that it's bound so tightly that the testosterone is not available to the cells. It's almost like a reservoir going through the body. It does come off slowly, but that portion is not bioavailable. The bioavailable, the other two portions there, shown in purple, the part that's albumin bound, which is weakly bound, so it comes off when it needs to. And then FT stands for free testosterone, which means it's unbound, and it makes up about 1 or 2% of the total. So with that in mind, this is an important slide. This is data from the European Male Aging Study. And what you see in 5-year increments going from left to right is 4 different hormones. So in the top left is total testosterone. And you see that it declines over time, but it's really not a very impressive decline, is it? Almost flat. But if you look at the free testosterone at the top right, you see there's a real decline. And what accounts for that difference, just below that in the bottom right, is SHBG. As we age, SHBG goes up. It binds more of the total, and the higher your SHBG, it means the more your total will look normal, even though your free, which we use as a surrogate for what's biologically available, even though your free may be low. So if you see a guy in your office who's got classic symptoms, but his total testosterone looks normal, make sure you get an SHBG and or a free testosterone, because some of those guys really are deficient in testosterone. Their body is telling you that, but their total testosterone doesn't reflect it because of SHBG. And if you look, LH is for the pituitary gonadotropin that tells the testicles to make T. That goes up as we get older too, because the testicles aren't responding as well. So who's a candidate for treatment? The Endocrine Society recommends that you use your own laboratory reference values. I disagree with that. We published a paper some years ago. We just polled 25 different labs, and out of 25 labs looking at their reference values, we got 17 different reference values. So they're all a little bit different. I actually would prefer that you use some threshold that makes some sense. FDA mandates that pharmaceutical companies use a level of 300. International groups, of which I've been a member, have put out recommendations of less than 350. But understand that that's going to account for 90% of your guys, if they're less than 350 with symptoms. But you're still going to have some guys who have generous SHBG levels, who may have a total testosterone of 400 or 500, rarely even higher, but with very high SHBG, they can still have low levels of what's biologically active, which we look at usually with the free testosterone. The Morgentaler criteria is that you have to have symptoms or signs. Low values for total or free T is confirmatory. We use a value of 350 for the total, but we recognize that FT, which is free testosterone, is often really what's low, and there are different values for that depending on the lab. And if the free testosterone is low, the total testosterone doesn't actually matter. And if you're going to give treatment, it takes a while for things to happen. So no, it's not like a light switch going on for somebody. You have to tell them it may take 3 to 6 months. At the end of it, one of the things that really kills me is there's often this, in a lot of lectures, people say, you got to be so careful about making the diagnosis, because once you make it, that man is going to be on it for life. Sounds like a prison sentence. In fact, you can go off it any time you want. It's a trial of therapy if we're doing it for symptoms. The guys who really needed it for life were the guys with Klinefelters or absent testicles or the pituitary hormones, pituitary tumors. Those guys really did. But they make up a small fraction of the men today that we actually treat or consider treating with low testosterone. I know that most of you are not doing sexual medicine or urology, and the thing that's really changed for us now is that there's more and more evidence that what's important about testosterone isn't just sex, but it's about general health issues that you care about for your patients. So we find very high prevalence rates of low testosterone in men with all the big conditions. Obesity, about half of the men will have levels of testosterone under 300. Diabetes, about the same. Patients with AIDS have very low levels. Hypertension, about 40%. You see over on the left, chronic opioid use. So this is not how low their levels are, but what percentage in those populations have low levels of T. Chronic opioids give us some of the lowest testosterone levels that I've ever seen. Some of them approach castrate. So those, and the pain medicine guys are actually getting on the testosterone bandwagon, and actually a lot of them now tell me that they treat some of their guys with T and try and get them off some of these other things. It turns out that independent of symptoms, if you just take populations in longitudinal studies where they follow men for 5 years, 10 years, 15 years, sometimes longer, and you draw blood at the beginning and you freeze it, and then at the end of your study period, you go back and look who's developed what new problem. You find that men in the lowest 25% of T levels for whatever population you're looking at, you've all heard of like Rancho Bernardo studies and those like that, being in the lowest 25% doubles your risk of developing de novo diabetes, doubles your risk of developing de novo metabolic syndrome, triples your risk of developing osteoporosis or osteoporotic fractures, just by virtue of having a low testosterone level. Whether it's causative or a marker, uncertain, but a lot of the things improve when we actually treat. So if you give testosterone therapy, we actually decrease, multiple studies now show, fasting blood glucose goes down, HbA1c goes down, insulin resistance goes down, waist circumference goes down, and metabolic syndrome goes down. So those are all sort of surrogates, if you will, for sort of general health that seem to improve. What about men in osteoporosis or men in bone density? So if you've got low testosterone, you're at risk for osteoporosis. You just are. Men get it not as often as women and delayed by about 10 years, but they do get it. And one of the known risk factors is testosterone deficiency. This is a 3-year study where they looked at giving testosterone only. T plus F is testosterone and finasteride. You guys know finasteride, it's Proscar or Propecia. It blocks the conversion of T to DHT, dihydrotestosterone. And you can see that compared to placebo, both of those curves showed very nice improvement in bone mineral density. The fact that T and TNF have the same curves suggests that finasteride doesn't do anything, which means DHT probably doesn't do anything for bone. DHT is an important androgen for prostate and for scalp, which is why they use it in the form of Propecia, but not for bone. That's a testosterone effect, and it shouldn't be a big surprise because testosterone gets converted to estradiol. I'm sure Dr. Altman's going to be addressing some of that in his talk. So estradiol has clearly beneficial effects on bone. Turns out testosterone has independent beneficial effects on bone as well. Some of it is T and some of it is by conversion to estradiol. We published this last year. We do body compositions as well as DEXAs in these guys. And this was a retrospective study, but we looked at the changes in muscle and fat in 58 men who had low testosterone. We got this body composition, which uses the DEXA technology. It's the same thing, dual X-ray absorption. Before and roughly 6 months after they start. Mean age was almost 58 years. They'd been on therapy a little bit longer than 6 months. And lean mass increased, which is muscle, increased by 2.5 pounds. Now, you may not think that that's a lot, but 2.5 pounds is about the weight of an extra biceps. Who wouldn't like to have an extra bicep, right? It's not an insignificant amount. And fat mass decreased by 2 pounds, and body fat decreased. So there's a lot of negativity about hormones for men and for women too, and I'm sure you're going to get into it in the next talk. And there's a lot of thoughts about testosterone that it's really been all about sex, and I'd like to suggest it's time for a little bit of a different perspective on it. The big issue for most of us has been the prostate cancer story. So everybody in this room knows that if you have a patient with metastatic prostate cancer, that one of the treatments, almost all of them, are going to get some medicine like Lupron, a GnRH agonist, that's going to drop their testosterone to castrate levels. When I was a resident, we still did bilateral orchiectomies in these men. And they'd come in with bone pain, widely disseminated cancer, and sometimes within a few hours, they would feel better. If you do that, you can get a PSA of, let's say, 200 in some of these guys, and it can go down to become undetectable. That's real. So people worry about testosterone, and we see the benefits of lowering testosterone in men with prostate cancer. But sometimes things aren't exactly the way that they seem. So when I came out of my training, I learned, like many of you, that high testosterone caused prostate cancer, or predisposed to it, that low testosterone was supposed to be protective. How many of you heard that if you were castrated early in life, you'd never get prostate cancer? Yeah, many of you. And that if a doctor were stupid enough to give testosterone to a man with existing prostate cancer, that cancer would grow like wildfire. And we all learned, let me ask you, show of hands again, how many of you heard that giving testosterone to a man with prostate cancer is like pouring gasoline on a fire? Everybody, around the world, or feeding a hungry tumor. So when I started doing this work, this is what I worried about too. I mean, I was impressed by what my patients were telling me. And I worried about the cancer. So I'm out in practice a couple of years, and I run into one of my colleagues who had taught me at our national meeting, and he says, "Abe, I understand you're giving testosterone to men." We share residents, they go to different hospitals. So there's no secrets, right? And they'd heard me talk about how I thought it was cool. And he says, "I don't think you should do it anymore." I say, "What do you mean?" He says, "I tried it on a patient. And within 9 months or so, his PSA went up, I biopsied him, he has cancer. So you can't give testosterone." I suggest you stop. And if you do it, you better be sure you get a biopsy beforehand. Make sure they don't have cancer hiding in there. So I was pretty young, wet behind the ears. I went to my chief. I said, listen, I ran into Dr. Laughlin. He suggested I biopsy these guys. I'm already worried about prostate cancer. I'm already telling them it's a risk. I want to biopsy them, even if their PSA is normal. He says, okay, do it. So I started biopsying men who were normal, except for the fact they had low testosterone. PSAs were normal, which we defined then as less than 4. Their prostate exams were normal. And I wanted to make sure they didn't have a cancer hiding in their prostate that would grow if I treated them. That was the only reason I was biopsying them. And we found cancers right away. These were guys who were supposed to not get cancer. Low testosterone was supposed to be protective. When we had something like 6 cancers out of our first 33 guys, we presented it at our national meeting. And Bob Crane, who was an international figure, but more importantly had a huge booming voice, got up at the end and he said, "This is garbage. Everybody knows high testosterone causes cancer. Low testosterone is protective. You guys stuck your needle someplace you never should have stuck it. You found some cancers you never should have found. I'll bet you dollars to donuts." I remember every word of this. "I'll bet you dollars to donuts. You biopsy the next 100 guys like this, you won't find another cancer." So when we had 50 guys and the rate was the same, I submitted it to JAMA. And never happened to me before, never happened to me since. The editor calls me and says, "Our editorial board has looked at this. We think this is pretty interesting because it's the opposite of what we've all been thinking. Low testosterone, high rate of cancer. We just wonder if maybe you found some cancers you shouldn't have found." Kind of like what the other guy was saying. But I tell you what, if you've got more guys, and you've probably accumulated them by now, and if your numbers hold up, we'll consider publishing it. And so in JAMA in 1996, we published on first 77 guys with normal PSA, normal digital rectal exam, these results. It was 1 out of 7 guys with low testosterone had cancer. And if we publish, this is a figure out of that article. And if you look in the middle in the white, that's our rate of cancer, 14.3%. The studies above it were cancer rates in men who had normal PSAs but were considered suspicious for some other reason and had biopsies. And their rate of cancer was 0 to 4.5%, pretty low. And the studies below it were studies of men who were known to be at increased risk, either because they had an abnormal prostate exam or because they had elevated PSA. And I would suggest to you that our rate of cancer in these men with low T looks more similar to those guys who are at risk than the other guys. We didn't say that, but we kind of suggested maybe there's something going on. So what I got out of that was that low testosterone could not be protective. It's not. And I went to the literature and looked up where that came from, and it came from a undocumented comment in the discussion of a paper in rabbits from 1948 where they manipulated hormones, and they said, but of course, something like, of course we all know that men who are castrated early enough in life or lose their testosterone never get prostate cancer. In 1948, how many physicians do you think had a large cohort of patients who'd been castrated early in life, and they then had followed them for 50 years to figure out if they could develop prostate cancer? It was just somebody just threw it out there. So low testosterone wasn't protected, but I still absolutely believed that high testosterone was a problem. I was worried about these guys. Until I wrote this paper with my fellow from Brazil, Hernani Roden. So this was a paper for New England Journal on the risks of testosterone. And they were particularly interested, New England Journal was, in prostate cancer. And we pulled a few hundred papers, and we're getting ready to draft the article. And Hernani, who's from Brazil, says to me, "Chief," he looks a little uncomfortable, "do you have the articles that show that testosterone is bad for prostate cancer?" I said, "Hernani, I thought you had them." In the end, the number of articles that we found in the PSA era, which begins in the mid-1980s, to when we wrote this paper that showed something negative about testosterone and prostate cancer was 0. The data did not exist, and yet every single physician would have said, absolutely, there's a relationship. I didn't come into it with any agenda. This is just, I absolutely believed it was true too. I just couldn't find the evidence for it. So where did this all come from? So a colleague of mine who's a prostate cancer guy, we're like on the lecture circuit, he says, Abe, your stuff's pretty interesting. But I got to tell you, you got to be careful. Because Charles Huggins said that if you give testosterone to men with prostate cancer, it grows like wildfire. Now, Charles Huggins, anybody know Charles Huggins? Charles Huggins is the patron saint of urology. He is the only urologist to ever win a Nobel Prize for urology. And he was the guy that figured out in 1941 that if you castrated men with metastatic disease, that they got better, at least temporarily. He didn't have PSA back then. They used another chemical, which some of the white guys with white hair here will remember as acid phosphatase. Remember that? Yeah. And acid phosphatase was very erratic, and it was only useful in metastatic disease. But that's what we used. And we don't use it anymore because PSA, even with all its limitations, is still worlds better than acid phosphatase. Oh yeah, so this was me talking about prostate cancer and testosterone. It wasn't always a good welcome. There was a lot of resistance. So I went to find Charles Huggins. And in the basement of the Harvard Medical Library, Cantway Library, you can pull out bound journal. This is before PubMed. You can pull out these journals that go back to the 1800s, like Lancet. And there is his article from 1941 that is entitled, The Effect of Castration of Estrogen and of Androgen Injection on Serum Phosphatases, acid phosphatase, in metastatic carcinoma of the prostate. Huggins and Hodges. And I'm reading this, and he says, in every man that we gave testosterone to, the acid phosphatase went up, showing progression. Testosterone activates prostate cancer. So, and when we removed the testicles, acid phosphatase fell. Thus it is proven. So I read this and I go, huh. And then I read it again. I say, how many guys did he give this testosterone to? Amazingly, he only gave it to 3 guys. In the results section, he only gave results for 2 guys. One of those men had already been castrated, which we know puts him in a whole different category of androgen deprivation. In the end, the idea that testosterone makes prostate cancer grow like wildfire, or pouring gasoline on a fire in the general male population, is based on a single patient. What do modern data show? Well, this is a pooled longitudinal set of data, huge study, over 3,000 men with cancer, over 6,000 age-matched controls, looking at quintiles, lowest 20%, next 20%, et cetera, for testosterone, free testosterone, DHT. There was no relationship. Men with the highest testosterone levels were at no greater risk of developing prostate cancer than men with the lowest 20%. In the placebo arm of what's called the REDUCE trial, it was a trial with Avodart, but it doesn't matter much because this is the placebo arm. They had blood tests in these men, and part of the study was to do prostate biopsies in all of these men at year 2 and year 4. They all got prostate biopsies, and they compared the results of those biopsies, cancer or no cancer, with their baseline testosterone values and DHT values. And the bottom line was there was no relationship whatsoever. What about meta-analysis of testosterone trials? This is one by Kaloff et al., 19 placebo-controlled trials. If you look at men who got testosterone versus men who got placebo, there's no difference in the rates of prostate cancer, no difference in the rates of men who developed a bump in their PSA above 4, and voiding symptoms didn't change either, which we also think of benign prostate as being very androgen dependent. So I came up with a model that I published on a couple of times. One was with Abdul Traish, who's a biochemist at BU, and we call it the saturation model. And it explains why, when you drop testosterone into the castrate range, you do see beneficial effects. If you take somebody with very low levels, and you, like castrate levels, and you raise it like one of Huggins' patients, you will see an effect, like a rise in PSA. But over most of the course of testosterone, if serum testosterone here, whatever kind of marker you want for prostate cancer here, whether it's PSA or prostate cancer, it goes up and then it plateaus. No one has ever been able to show that men with very high levels of testosterone have any different risk or any other problems versus men with middle levels, low levels, even slightly subnormal. But once you drop enough, you get into changes. And it's actually, especially for the younger crowd, this is not difficult to understand. When Huggins did his work, nobody knew about hormone receptors. But here's how it works. So imagine this is a prostate cell or a prostate cancer cell. T enters, gets reduced by 5-alpha reductase to DHT, which is the primary androgen in the prostate. It binds to AR, which is the androgen receptor. The complex of androgen and androgen receptor moves to the nucleus, binds to androgen response elements on the DNA, and does whatever trophic effect it's going to do on the cell. But notice that it's not T that does it alone, it's not DHT that does it alone, it's not even the androgen receptor alone that does it, it's the complex of these. And we have a limited number of androgen receptors per cell, and once they're all bound to androgen, what's going to happen if you add in more? This mechanism can't translate into anything further, it maxes out. So that's what we call saturation. So I like to say that testosterone isn't like food for a hungry tumor. It's like water for a thirsty tumor. And the difference is when you drink more than you really need, what do you do with the excess? Yeah, you get rid of it. So I've got a plant like this at home. Well, I don't anymore, but I used to. And think of the plant as the cancer and think of water as testosterone. Okay? So if you don't water it, it shrinks. It loses its mass. It loses its volume. Right? It's deprived of its nutrient. If it's deprived of its nutrient, but it's still alive and you water it, it's going to grow. Gain mass, gain volume. But once it's got its full size and it's happy, you could have a garden hose running in there 24 hours a day at full blast. That plant is never going to grow to be the size of a sequoia tree. It satisfied its requirement for whatever that nutrient is or growth factor. And that's what prostate cancer looks like, and your prostate in general, both in humans, animal studies, and also in prostate cancer cell lines. So some brave men or individuals have actually started to offer testosterone therapy to men with prostate cancer. And so the first stuff was in men after radical prostatectomy, where after a few years they look like they're cured. If you don't have any prostate cancer cells in your body, even if testosterone were really bad, nothing should happen. There's no cells for it to act on. So there have been a few reports on that with about, not that many, about 130, 140 men without recurrences, published, a few different studies. They've given it to men after brachytherapy, which is like these radioactive pellets we put in for prostate cancer. Also, I think it was 4.5 years of follow-up, no recurrences. So I started giving it to some men with prostate cancer that was just being watched. We call it active surveillance. My first case was an 84-year-old guy who came in. He was a lawyer, beautiful shock of white hair, went to work every day, still sharp as a tack. And he came in, he had some sexual problems, he couldn't climax, and his desire was down. And I said, it's probably low testosterone at your age, it's likely. And I get a PSA on him, and it's 8, pretty high. Repeat it, it's 8.5. So I had a conversation with him. I said, listen, I don't do a lot of biopsies, prostate biopsies. I'm in their 80s, but your PSA is pretty high, you're pretty sharp. If you've got an aggressive tumor, maybe we should know about it. If it's not aggressive, we could watch it. So he says, I'd like to know. So I biopsy him, and I don't do, you can take different amounts of pieces sampling, and I really don't, normally we do 12. Some guys do more. I only did 6 in him. I didn't want to look too hard. But he ended up with Gleason 6 cancer, which is sort of our quieter prostate cancer, on bilaterally in his prostate. So we have a conversation, and he says, I don't want to treat it. I just want you to watch me. I said, I think that's perfectly reasonable. And I'm ready to leave the room, and he says, but doctor, what about testosterone? You told me it would help me, or you thought it would help me. I said, I can't treat you. You've got untreated prostate cancer sitting in your body right now. He says, but you said it might help me. I really would like to be helped. I said, it's funny because I give a lot of talks about testosterone, and I've given it to a fair number of men after they've had surgery for it or radiation, but I've never treated anybody like you. He says, what do you think would happen? I said, well, I don't know, but your prostate cancer could grow and you could die. He says, doctor, he's a smart guy. He says, if the testosterone makes my cancer grow, won't my PSA go up? I say, probably. He says, and if it went up with testosterone, we stopped the testosterone, would it come back down? I said, I don't know that for sure, but probably. He said, doctor, I'm 84 years old. He says, I don't really see that I have much to lose, and I'll sign whatever you want. I'd like you to treat me. So I wrote this long handwritten, now we've got EMR, but I wrote this long, it's about 6 years ago now, handwritten note. He knows he could die, blah, 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 and ended up publishing on him. So he was the first guy that I knew of with untreated prostate cancer sitting in his prostate. We're raising his testosterone. His symptoms got better, and this is what happened to his PSA. He started at 8 and 8.5. He went down into the 7s, went down into the 6s, went down into the 5s, and then he eventually plateaued around 6. He was my patient on testosterone until he turned 90 this year. Came in with his wife, he's starting to lose it, and we stopped the testosterone. 5.5, 6 years of testosterone therapy. And he gave me the courage then a few years ago to start doing it in younger men. And so we published 2 years ago, 13 guys together with my colleagues at Baylor. Median duration of testosterone was 2.5 years. All these guys got follow-up prostate biopsies, which my older lawyer did not, just because of his age. And this is what happened to PSA. So this is their baseline PSA before starting testosterone. This is 3 months, 6 months, 12 months, 24 months. PSA never budged. All men got benefit symptomatically, which is why they stayed on it. PSA didn't change. Prostate volume didn't change. None of these men had any definite prostate cancer progression. And in more than half of the biopsies, we didn't even see cancer again. Now, I'm not saying we cured anybody. These were all low-volume guys, low-volume disease to begin with. Maybe the biopsies missed it. But certainly nothing happened. So we just had our national meeting 2 weeks ago, and we just won first prize for presenting our updated data now in 33 men, all at our center. Similar kind of story. Nobody really progressed. When I say really, the reason I say that is because when you do multiple biopsies, sometimes the grading will go from a Gleason 6 to a 7, and you repeat, it goes back to a 6. But nobody had any definite progression. And that's where we are now. So the question is, why do we fear testosterone? I love this quote from Charles Darwin, who wrote that it is worthy of remark that a belief constantly inculcated during the early years of life, while the brain is impressible, appears to acquire almost the nature of an instinct, and the very essence of an instinct is that it is followed independently of reason. We believe that testosterone is bad for prostate cancer because all of us had our teachers tell us that it was so. But the data don't support that. Now, the one comment I would make is, I don't want you walking around and saying, oh, I can give testosterone to anybody with prostate cancer. So I told you about our experience with it. But those are all guys with low-grade tumors. It's a small sample. I have no idea if the next guy that we treat is going to have something bad happen to them. But I can tell you that it's the first time since Huggins in 1941 came up with the idea, 70-plus years ago, that anybody bothered to look at what happens inside the prostate of a guy with cancer when we raise testosterone. And the old idea that testosterone necessarily makes prostate cancer grow cannot be true. So should you care about testosterone? I think you should, because some of the most provocative data now are coming out around mortality and longevity. This is out of the VA in Washington State. You see 3 curves. As they come down, it means that people are dying. This is cumulative survival on the y-axis, and then time on the going left to right on the x-axis. The curve at the top is men who had 2 testosterone levels that were both normal. The next curve down is one was normal, one was low, and the one at the bottom was too low values. The lower the testosterone values, the sooner men died. There now are approximately 6 or 7 of these studies from different population groups, almost all of which, 1 or 2 did not show this, but several of which have shown it. And then from the same group, this is retrospective now, did something amazing, which is in the VA system, they can tell who's actually received testosterone because they've got all the pharmacy data. So if they looked at men with low testosterone and they looked at the subgroup that received treatment, the mortality was decreased over this time period from 20.7% down to 10%. Mortality decreased by half. We have to be careful. It's not a prospective study. It's uncontrolled, but it is extremely provocative. If you're going to treat, we got a couple of different choices. The injections have been around forever. They're inexpensive, but not everybody wants an injection. I told you when I started, we did it every 4 weeks. We don't do that anymore. We do it 1 to 2 weeks. We have a lot of in my practice, we use a lot of these pellets. We put them under the skin of the bum. It's a little procedure. It takes about 5-10 minutes. The nice thing is that it lasts about 3 months, so the guys can forget about it. Number one product in the United States, there were the various gels. They're all marketed. That's the commercials you see on TV. There now are 4 different ones. They work, but be aware that 20% of men don't absorb it well through the skin. So you can't assume that just because you've prescribed it and the guy says he's applying it, that he's going to get good testosterone levels. If you have a guy who starts with a T of 250 also, and you get him up into the quote-unquote normal range of, let's say, 350, the lab will say it's normal, but most guys really don't get their optimal response till they're mid-level, and some guys actually need to be in the upper third of normal. And so you have to often tweak the dosage with the gels. I say you have to check your levels in the guys getting the gels, and you often have to adjust the dosage. So if a guy comes to start at 250, comes back at 400, and he says, I feel great, thank you so much, you leave him there, whatever dose he's on. If he comes back and he's 400 and he says, I'm not getting that much, you can increase the dosage, and he may respond at 500 or 600. Patch has been around for a while. I'm not a big fan. It's a clever idea, but we don't get great levels in those men generally, and there's a fairly high rate of skin irritation, so the gels have totally leapfrogged that. There are oral forms of testosterone around. Do not prescribe them. They've been around, grandfathered in, but they all cause liver toxicity, which none of the modern forms of treatment do. So don't use them, and if you do, you have to check levels. So I've told you about prostate cancer. I don't think prostate cancer is a risk. This may be a risk. Guys and testosterone, what are we going to do, huh? There are some medical risks, though, other than bad driving. You do have to watch the hematocrit. So testosterone will increase the hematocrit by, on average, about 3%. So, for example, from a level of 45% to 48. We allow it, it happens so frequently that we actually allow men to be supraphysiologic with it, to get crits above 50. But we, together with many other groups, published guidelines, will allow it to get up to either 52, and we use it up to 54%. Without stopping it or changing the dose. But that is one of the things you have to monitor men for. You can get gynecomastia from conversion of testosterone to estradiol. It's rare and it's reversible, and you can use an aromatase inhibitor if it happens to block it again. Men who are on exogenous T get suppression of their gonadotropins. Their testicles will shrink a little bit, and they'll stop making sperm as well. So some guys, if you have to ask a younger guy especially if he's interested in making babies anytime soon, because if he is, you can't give him exogenous testosterone. Some men will get pimples they haven't seen in years. There's no negative effects on heart or voiding, and the historical concerns regarding BPH and prostate cancer does not appear to be supported by the evidence. So to finish up, these are my takeaways, if you will. A normal serum testosterone is associated with better health and increased longevity. I'm not prepared to tell you that it increases longevity, but the association at this point, I think, is actually fairly robust. Serum T, or in my opinion, free T is better, may be the single most important indicator of overall male health. I think it easily trounces cholesterol, glucose, and PSA, which all help you around very specific issues. Testosterone is involved with well-being, bone, muscle, prostate, glucose metabolism, and now possibly longevity. And T therapy produces benefits in most men who have a deficiency, often with an improved quality of life. If you treat, hopefully your patients leave the office looking like this, as every single one of my patients does. Thank you very much. We have time? I think we have a few. I went a little bit long. We have time for a few questions, yeah? I think there was one started there.
Three quick areas.
Quick.
If you're going to use aromatase inhibitors, what's your dosing? What percentage of your folks are using that? The second thing, would you use HCG?
I don't have a good memory, so I'm going to do it one by one. So the answer is rarely, and the dose is 1 milligram a day of anastrozole.
Okay. HCG for testicular volume.
So HCG is fine. HCG mimics luteinizing hormone. So younger guys, especially who want to maintain testicular volume, will use it. We use it in men with infertility. I told you we can't use exogenous T. You can use HCG, but it's an injection. You have to do it 2-3 times a week. Not that acceptable to a lot of people.
DHEA and keto DHEA for
DHEA is an over-the-counter supplement. It's really an adrenal androgen. Weak effects in men may be more likely to be beneficial in women.
Okay, if someone gets a high hematocrit, so 56, 57, you just have them donate blood, what do you do?
So if it happens on treatment, we either stop it for a while, lower the dosage, or some of these guys really feel like they need that level. We'll do a therapeutic phlebotomy or have them donate blood. Here in the mountains, a lot of the guys start off with high crits. And the old sort of cutoffs probably don't apply as much, and you have to use local wisdom.
Second question. For younger men, I've had some come in, they're 32, 33, and they got a total testosterone of 200. Do I need to do a workup on them before? Do you get a brain MRI to look at the pituitary gland? Do you check LH-FSH? What do you do?
Good, thank you. So I'm sorry I left it out. So I think the workup for a guy who comes in with symptoms suggestive of low T is total T, free T, LH, crit, or hemoglobin, whichever you like, and PSA. I think that's your workup. If you want to do a little more extensive, maybe you get an FSH, maybe you get a prolactin. The yield on prolactinomas can do this, but the yield is pretty low. And if you're interested in metabolism, I think a DEXA scan is reasonable. And good. So if they're young, they don't need a PSA. But the younger they are, the more you need to worry about pituitary imaging. So if it's just a little low, I don't think you need to, unless the LH is also low. So low testosterone with low LH, and usually low FSH goes with it, mandates imaging. And even men, the endocrinologists recommend that a super low T is like 150 or so. Even if everything else looks different, get pituitary imaging and CYA, right? Cover your backside.
Could you comment on the suggestion from some that there might be an increase in the higher grade malignancies in prostate on people on testosterone?
Yeah, thank you for the question. So actually, the evidence is the opposite of that. So people have worried that high testosterone is associated with high-grade or aggressive cancer. It turns out that the opposite is true, and the evidence is either neutral about high testosterone, like it's not there, or it shows that low testosterone is a problem. So I've got a series of slides, which I don't have here. Low testosterone in many but not all studies is associated with higher risk of a positive biopsy, like what we did, higher risk of high-grade cancer, higher risk of positive margins at the time of surgery, and higher risk of biochemical recurrence after surgery. I'm worried about low testosterone these days, not high testosterone.
Really cool stuff, thank you. First, timing of the draw on the testosterone, free testosterone, and second, sleep deprivation and testosterone levels.
Great, so sleep deprivation, any impaired sleep can result in low T. You never get a testosterone when people are stressed, like in the hospital. Don't forget about it. Their levels are all down. Men with sleep apnea often have low testosterone. But it's an interesting relationship that goes both ways, because when we treat men with testosterone, they often will tell us that they're sleeping better and more soundly. So that's an interesting back and forth. The first part was?
When do you draw your testosterone?
So if this is a board question, the answer is in the early morning, between 6 and 10. If this is a practicing physician conversation, it's you get it when the man comes in your office. And and the reason is that this diurnal variation, which is real, is blunted remarkably in men over 40 and with any medical issues. So it's only the healthiest guys that have shown this diurnal variation where it's highest in the morning. I will tell you this without getting into too much. It never made sense to me anyway, because if you want to figure out if somebody's got heart disease, do you do their EKG when they're just lying quietly, or do you actually get them up on a treadmill to see what's what? So there are a lot of guys who have, younger guys who have normal T's in the morning, they're low in the afternoon, and a lot of folks will dismiss that and say, well, it's not real, but they've got every symptom under the sun and they do respond to treatment. For men above 40, there's really no difference. We published the largest cross-sectional study in over 3,000 men looking at time of day and T levels. It was actually during Prostate Cancer Awareness Week. They're getting their blood for PSA really, but we added in testosterones. And between the hours of 6 to 10 in the morning, 10 to 12, 12 to 2, there was no difference in these men. Now, they're all over 40, all over 50, actually. There was a small decrease in the late afternoon by 13%. Not enough, really, to mess up your diagnosis.
Could you comment on the apparent contradiction between the study published in the New England Journal a couple of years ago showing increased risk of stroke and MI in older men given testosterone and the data you showed us about apparent improvement in cardiovascular risk parameters?
Great. So there are about 30 studies that have looked at testosterone and cardiovascular issues, of which 29 show either no effect or a beneficial effect of testosterone on all sorts of heart parameters, including placebo-controlled studies giving testosterone in men with moderate to severe congestive heart failure, showing benefits of testosterone versus placebo. They've given men with angina testosterone versus placebo, put them on treadmills where they have exercise-induced angina, and the guys on testosterone have longer intervals of exercise without getting angina. But a couple of years ago, New England Journal, bless its heart, published an article by a great group, I know them, they're super investigators, that was designed to look at testosterone in frail older men. It's important. So they were looking at frailty, because muscle, all that stuff, right, bone. And what they showed as their conclusion of that study was testosterone versus placebo did, in fact, improve their function. This was a group who could not, to be in the study, they couldn't walk up a flight of stairs. That was their inclusion criteria. And at the end, they published this thing that scared the dickens out of people, because the testosterone group got more cardiovascular effects, adverse effects than the other. But if you look at that, what they found, most of those things, none of you would accept as being certainly major cardiac events. So it was anything that was reported by the patient, by referring docs, or the study investigators, including pedal edema, which can happen with some testosterone. You can have some fluid retention, especially in a group that can't walk up a flight of stairs. It included palpitations. It included, this one I love, EKG changes during stress tests. Now, stress tests were not part of the study. So what were these guys doing getting stress tests? And it didn't happen in all of them, right? Like they weren't all getting it. So it was a congregation of stuff. There were 2 MIs in the study. They did happen to both be in the T group, not the placebo. But in a previous meta-analysis, all the MIs had happened in the placebo groups, not the T groups. On balance, I think those things are all set. So that's what that was. Nobody in the field, it's called the Tom trial. It raised a lot of concerns, but not from people in the field. Yeah.
What would your recommendation be to a patient who has been diagnosed with PIN on biopsy, who is symptomatic, laboratory confirmed, stable PSA, normal DRE?
Great. So PIN is high-grade prostatic intraepithelial neoplasia. And for about 15 years, we thought that that was a risk factor for turning into like a precancer for prostate cancer. There's one paper on it. It's ours. We treated these men with testosterone. Nothing happened. But which was kind of cool at the time, and people congratulated us for being brave. Today, the whole story has changed, though. So today, PIN by urologists and oncologists is not considered a very significant issue anymore. When there's a ton of it in the prostate, we worry there's cancer somewhere else, but we don't really worry about PIN. So go ahead and treat that guy. He does not have cancer.
If he hasn't been biopsied for several years, but that's the other picture, would he need to be re-biopsied?
If he's had a biopsy, it showed only PIN, and his PSA is stable, you're all set.
The last question, is the low sperm count and infertility reversible? When you said that committing to testosterone replacement is not a lifelong commitment necessarily, is that reversible?
It is.
When you stop
It
therapy?
is. They've done quite a number of contraception studies in men using testosterone to suppress spermatogenesis. They stop the testosterone, everybody gets their sperm back.
Thank you.
Last question, I think then we have to go.
If you're treating at the maximum dose levels that are allowed, and whether it's injectable or topical, and their levels don't come up, what do you do?
So injections, everybody gets it, but injections, it's a moving target. So if you give a guy an injection and you measure his blood at 2 weeks, he's going to be back at his low baseline level. It's going to look like he never raised it, but you actually just get the blood test earlier. But guaranteed he raised it. And with the gel, some people don't absorb it. A couple of tricks. One is change the gel, and the other one is try a different formulation of testosterone. So if he was on a gel, try him on an injection or a pellet or something like that. Thank you all very much.